The next speaker we have is Dr. Prasanna. Dr. Prasanna is a senior consultant and director of the Mahatma Eye Hospital at Trichy. And Dr. Prasanna is going to talk to us on real disease. So the last is always the best. So we have him speak to us on actually what you should see in a glaucomatous field and OCT. Over to you, Prasanna.
Thank you, ma'am. Apologies for the delay in arriving, ma'am, due to inevitable reasons. Thank you for the opportunity, Chandrima, ma'am, Anujit, and the whole team of instructors. So I'm going to talk on real disease on OCT and visual fields. And it begins with a few of the structure that I've used in this presentation is going to be a structure function correlation, because that's how it really be in our practice in real time. We'll be always using the visual fields, OCT and fundus together. So it starts from the molecular level, which is the basics of the retinal ganglion cell damage which is well documented. And in glaucoma, we always expect, and theories are coming, that even demyelination can be an early change in glaucoma. Or the retinal ganglion cells, we have the differential that I think Arijit sir also would have covered on neurological aspects, which are a very important differential diagnosis. So the markers are the neuroretinal rim thinning and the retinal nerve fiber layer loss, fondly recently told as the BMO MRW in the spectralis mission, called the Brooks membrane opening minimum rim width. And there are key functional markers that we need to keep a track on, be it visual fields or OCT. We cannot rely on one domain to support the interpretation. We need to be clinically multifaceted with all the instruments and make the instruments work for us rather than making it work for you. So the structure function correlation, fundus, visual fields, or maybe the OCT, ERG, whatever that we have, and the structural damage correlating with the functional damage is the more practical approach, and combination of it is the way forward. So keeping in mind the linear measurements that happens with a structural damage, and correlating a logarithmic damage or the logarithmic scale in a visual field. That's the challenge, because both the scales are not proportional to each other, they are slightly disproportionate. So that is the reason why, when there is a 100 micrometer thickness drop in a RNFL, the decrease is directly proportional to the damage. But whereas if you see a 10 decibel drop in visual fields can reduce the sensitivity by 10 times, but a 20 decibel drop will reduce it by 100 times. So that correlation also plays a very important aspect in these things. And practical points, I've kept very cases for the next 7 minutes. G pattern, I use an octopus perimetry, no financial disclosure. It tests 59 points, and the points are not equally spaced. It's spaced in such a pattern mimicking the retinal nerve fiber layer, and that is one that really helps me in my armamentarium. Or the recent shift towards macular pattern, even in early glaucoma damages, that is something that from advanced you can use, or even for an early thing that we can use, because macula covers less than 5% of retina but contains 30% of retinal ganglion cells. And even you can see a simple 10-2 strategy compared to the M pattern. That is also something that I rely upon. And the simple parameters like G dynamic, which we do for the 24 degrees or 30 degrees, and then corresponding it with the 10 degree also plays a very important role for all practical purposes, because this is a real world where the theory is now moving from only advanced glaucomas we do 10-2. We are now slowly moving towards even early glaucomatous things where we can still do. So this is an advanced glaucoma where a G dynamic and now a 10-2 is actually seen. So correspondingly a 24-2 and 10-2 as an armamentarium in our real world, that is very important, and correlating it with different visual field representation. Meaning, for example, if you see this, you can always have a cluster analysis map also, where it gives you the RNFL. The functional analysis actually gives you what loss could have happened on a structure. So we are able to correlate that. Let's see a few more examples. The cluster analysis chart. This gives you an idea that these are the areas that RNFL could have been gone. So you can go back to your fundus or your OCT and focus on these areas. And this is a polar analysis which gives you more the lengthening of the lines here. It says that there could be a focal notch here. So go back to your fundus, go back to your OCT, check your notch, check your BMO, MRW, and see whether there is any notching in this region. And then you can correspond the RNFL which comes out. Then you can see the polar analysis, the notching, and then you can go for even ganglion cell inner plexiform layers. Another few example of my own cases here. Inferior RNFL defect corresponding to a superior arcuate scotoma. Now you need to move to the disc and correspond it to the polar analysis. So see the vertical cupping that you see here, and then focus on the visual fields where there is this lengthening of this red line in the polar analysis chart. See, they are corresponding to each other or correlating to each other. Are we going to use only one image in the real world? No. We need to have multiple images and document at least minimum 3 images or three sittings of the patient, and then you need to use MD, SLV, mean deviation, square loss variance, and then DD and LD. I'm not going into the depth of it, but these are the real world incidences. Again, another real world chart. Look at this patient from 2013, 14, 15 till now, and there is one graph here which is slightly offset. Can you see this Bebe's curve? It seems as if it's improved. If you see the strategy, it was G dynamic, G dynamic, G dynamic, then came a G top. This could be an error of a perimetrist, and then again it went to G dynamic. It will give you a false impression that it is actually right, or rather it is improving, but it may not be the case. So this area is slightly tricky. So you need to know your strategies. And again, a Brooks membrane opening minimum rim width is a very good tool because it has an anatomic positioning system, and it helps you even document 1 to 2 micrometers of tissue loss. So Madam would have covered in her talk in the morning in the GSA session as well, beautifully demonstrated by Madam, the Brooks membrane minimum rim width, which is slowly shifting towards, we previously had the horizontal rim width, now we are moving to this concept of minimum rim width. The horizontal rim width is slowly outdating, and this is my paper as well in the Indian Journal of Ophthalmology as to why it is important. And then these are some examples of the glaucoma module premium edition, where inferior temporal notch, see here in this region, my dear friends, there is a BMO MRW constriction. So we are slowly shifting towards this particular aspect as well. Why? You can see fundus appears normal, visual field appears normal, everything appears normal, but the BMO MRW in the inferior temporal area alone appears to be constricted. Pre-perimetric changes can be picked. Again, I think the IOP is under control and the patient is well controlled, but when you do a BMO MRW, you can see that there seems to be some progression which is still happening. So I now need to revise my target IOP. So again, diagnosing not only glaucoma, but subtle changes, even when the patient is on therapy, it plays a role. And also sometimes if you have an electrophysiological test, mild reversal signs like these can also be preserved or seen on a electrophysiological test and correlated with the structural OCT changes. You can see the mild reversal changes and few more cases as well. So this patient comes, there is a RNFL defect, BMO MRW defect, ganglion cell layer defect, and then correlate with the fundus. So you can see again, and then this is an inferior RNFL, correlate with the superior 24-2, and this is a 10-2. And then the BMO MRW is come down. Progression of disease, yes, you can see this is the previous image. Patient is coming up, follow-up is good, lost follow-up in between from 2013, and now the patient presents like this. See the same patient's cupping, and now I told you, right, this example. In between, once there was a misleading that the disease is actually improving, but actually no. And this was one of the progressive patients who lost follow-up. And then moving on to other examples, like for want of time, understanding the nature of disease. This is again another patient, OCT as well as the visual fields. I would always recommend you to see the RNFL or the disc first. Once you see the disc, go to the BMO MRW. Once you see the RNFL, go to the RNFL also in the OCT. Then come to the ganglion cell inner plexiform layer. Then correlate your 24-2 with RNFL and your 10-2 with ganglion cell inner plexiform layer. Also try to make the machine work for you by customizing the visual fields accordingly. If a patient is having this kind of scotoma, there is no point in testing the peripheries, or you need to focus more on these regions. So again, checklist is disc, RNFL, and then you go to the OCT and the visual fields. Another patient, a traumatic glaucoma. See this beautiful case, my dear friends. Day 1, 1 month, 3 months, it appears to be the same, but on a level of OCT, see how the damage has started at 1 month and 3 months. Structurally, it appears to be okay, but on OCT, you can see the documented damage, and even the RNFL is dropping, and then the ganglion cell layers, the RNFL loss, GCL, everything is actually going on and dropping down. Another case, last one, a neuro-ophthalmic case with a glaucomatic case. So if both are presenting together, what will you do? That's the confusion, right? So that is where I always go to BMO MRW. A patient with homonymous hemianopia came to me. IOP was also, phasing 21. I was a very tricky and challenging scenario. So what I did is I documented this and visual fields, OCT, 10-2, and I try to compare the patient from December till the next year. You can see that a simple progression can also be picked up with the Hood report that we have with Spectralis. You can see it appeared to be okay, or rather these are some of the things that gives you, even since 3 months or 4 months, you will be able to pick it. So I've also published all these cases extensively. To summarize, if you have OCT visual fields, use it to assess progression. Don't rely on a single test. This is a real world scenario. Rate of progression is a key. Be aware to correlate structure and function. Consider other factors and make the technology work for you rather than you working for the technology. And do tests based on the patient's condition. It doesn't mean we need to do everything for that patient. And beware of false positives, my dear friends, because that is a very important takeaway. We think there may be a disease, but there might not be a disease as well. So these are some of the examples I wanted to show. And thank you once again, ma'am, for giving me this opportunity to talk on the real world scenario in glaucoma. Thank you.
Thank you very much, Prasanna. That was indeed a very, very illuminating and interesting talk. And